Morning everyone. Today we'll be discussing about autoimmune encephalitis. So, definition for autoimmune encephalitis is the patient presents with these four typical findings. That is, there is a short-term memory loss, seizures, and psychiatric symptoms. All this correlates with temporal lobe and limbic lobe involvement. Short-term memory loss, seizures, and psychiatric symptoms. That is the first clinical finding. There is a less than 4 years difference between the onset of the symptoms and cancer diagnosis. Third is absence of metastasis or infection or metabolic causes in the patient with inflammatory CSF markers or temporal lobe EEG changes or temporal lobe MRI signal alterations which is seen. So this was first put forth by Gultikin et al. In 2000. This has been revised in 2007 by the addition of not just temporal lobe but also limbic lobe involvement to the spectrum. So if you have these four features together, then a clinical diagnosis of autoimmune encephalitis is made. So what exactly does the limbic system does? It helps us in the 5 activities, namely feeding, forgetting or memory, fighting, family, and fornication. So there are various components to the limbic system. There is a cortical component which predominantly involves the limbic lobe, the components of which are orbital frontal cortex, hippocampus, insular cortex, cingulate gyrus, and parahippocampal gyrus. And there is a subcortical component which consists of the amygdala, olfactory bulb, hypothalamus, anterior and dorsomedial nuclei of the thalamus, and septal nuclei. Coming to the site of involvement, the most consistent site of involvement in autoimmune encephalitis is limbic system, the components of which we saw in the earlier slide. But there could be variable involvement of the neocortex, striatum, hindbrain, spine, and peripheral nervous system. We should also remember there are certain subtypes which will lack any specific imaging findings. For example, the NMDAR type, which we will be seeing later. And there are certain subtypes in which the predominant involvement can be an extralimbic involvement, or there can be an equal amount of extralimbic involvement which will be seen in certain subtypes. Coming to the types, there is two different classifications. One deals with neoplastic and non-neoplastic. That is, majority of these autoimmune encephalitis can have an underlying cancer, which can be a small cell carcinoma, neuroblastoma, germ cell tumor, testicular or breast cancers, lymphomas, thymomas, or immature ovarian teratomas. Or sometimes it can develop per se without any underlying neoplasm. So it becomes mandatory for us that we have to check, we have to do a CT chest and abdomen to rule out these malignancies, to rule out any cause of this autoimmune encephalitis, whether there is a neoplastic type of autoimmune encephalitis that we are dealing with. The second classification, which is more important clinically, is the group 1 or group 2. Group 1 is intracellular. The antigen or antibody is directed towards the intracellular antigen, whereas in group 2 it is directed, the antibodies, the autoantibodies are directed, it is an autoimmune encephalitis. So the autoantibodies are directed against the surface antigen. How to remember which is one and out? Inside out. So the first one is group 1 is intracellular, the second one is out. So there are four important things, four important diseases which see in the group 1, which is anti-Hu, anti-MATA, anti-CV2, and anti-GAD. Whereas in the group 2, it is NMDAR, VGKC, VGCC, GABA-R. So if you find it very difficult to remember all this, just remember at least if it is like 2 letters or 3 letters, it belongs to the group 1. And if it is like the 4 letters, it belongs to the group 2 surface antigen. Group 1. The first one is the anti-Hu, which is the most common. Here, what we see is the medial temporal lobe involvement. We can see the amygdala, medial temporal lobes, hippocampus, which is all involved in this patient. There can also be brainstem and cerebellum involvement. These patients clinically present with epilepsia partialis continua, that is, seizures which are restricted towards the hands, feet, and the face. And the most common cancer which is seen with group 1 is always usually associated with cancer. So the small cell lung cancer. The another important thing that we need to know about, like group 1 and group 2, is group 1 has a worse prognosis when compared to the group 2 because there is underlying malignancy, and so the directed treatment is also not very good because these are the intracellular antigens. whereas the group 2 is more towards extracellular antigens. So plasmapheresis and the treatment works better for group 2. So this is a classical example of anti-U, in which the most common cancer which we see is the small cell lung cancer. Second thing is anti-MATA. This has a brainstem involvement. Anti-U had a temporal lobe involvement. Anti-MATA has a brainstem involvement. It can also have a medial temporal lobe or a thalamic involvement. Since there is a brainstem involvement, these patients predominantly present with the ophthalmoplegia. To complicate it clinically for us, sometimes these patients can present with nodular enhancement. So when nodular enhancement is seen, what we will be favored to think is there an underlying infective etiology. So that is something that we have to remember, that some types of autoimmune encephalitis can have nodular enhancement. Malignancy is associated with this is testicular cancer, small cell cancer, and breast. So we saw that the group 1 was having a poor prognosis because of they are directed against intracellular antigens, and so most of the plasmapheresis or the antibody depleting mechanisms or treatments might not work. But this has a good prognosis. When compared to all the group 1, this has a good prognosis because the testicular malignancy, we can do an orchidectomy. So the treatment, in fact, the treatment for some of the anti-MATA types will be to do an orchidectomy. Third one is anti-CV2. So we saw anti-U, anti-MATA, now we are seeing anti-CV2. Anti-CV2 is important in the finding that it has a striatal involvement. That is the basal ganglia. Here we are able to see there are symmetrical areas of basal ganglia involvement which is seen, which is extending till the bilateral putamen, globus pallidus, corona radiata, and centrum semiovale. It can also have a medial temporal lobe involvement. Since the striatum is involved, these patients will clinically present with chorea. Okay. And clinical and the important malignancies which are associated with anti-CV2 is going to be small cell lung cancer and malignant thymoma. Since it is basal ganglia which is involved, the first and foremost thing that we have to rule out before labeling something as anti-CV2 autoimmune encephalitis is metabolic and toxins. That is, you have to rule out hyperammonemia, hepatic encephalopathy, uremic encephalopathy, hypoglycemia. Hypoglycemia usually involve the occipital lobe, can also involve the basal ganglia, toxins, carbon monoxide, globus pallidus. These are the things which needs to be ruled out first before you label it as anti-CV2 type of autoimmune encephalitis. Second thing is these patients have also the similar areas of pulvinar, thalamus involvement which is seen in CJD disease, Creutzfeldt-Jakob disease. So what happens, how do you differentiate this? In CJD it is more of restricted diffusion which is seen in these areas, whereas in anti-CV2 type of autoimmune encephalitis, the restricted diffusion is not, there is no restricted diffusion. In fact, it is just involving with T2 and flat signal changes. Fourth in the group 1 is the anti-GAD. Anti-GAD involves the temporal lobe and limbic system. Clinically, this patient's presence is stiff Pearson syndrome. We can see in every slide I would have given, the green thing is the clinical syndrome, yellow thing is the malignancies which are associated with it. So these patients usually present with stiff Pearson syndrome, stiff person syndrome, and the malignancy associated with this is small cell lung cancer and malignant thymoma. Here the neocortex cingulate gyrus is all involved. Amygdala, hippocampus, basal frontal lobe, and insular cortex is all involved in this anti-GAD. This is one thing in which that can be associated. Group 1 was all neoplasm. This can present with non-paraneoplastic conditions, like in type 1 diabetes mellitus also you can have an anti-GAD. So not necessary that you'll get neoplasms always. In fact, in these patients, in this group, it's usually neoplasms are seen only in less than 10% of cases. So that summarizes our group 1, anti-U, anti-MATA, anti-CV2, and anti-GAD. Group 2 is directed against the surface antigen, better prognosis, and better treatment response is seen. And let's see since it is group 2, it will be usually all those voltage gated channels, receptors. These are the things which will be targeted. NMDA is N-methyl D-aspartate receptor encephalitis. NMDAR encephalitis. Again, limbic system and temporal lobe is involved. Insular cortex, bilateral basal ganglia, and temporal lobes and cingulate gyrus. These are all involved. Clinical profile, all this autoimmune encephalitis, the most important thing is the clinical profile. These will be young women and children. Most of this we have come to group 2, so they won't present with cancer. They won't have cancer, but some of these patients are also known to have incidental teratomas, and some of them also have ovarian cancer. We really do not know whether it is because of the ovarian cancer or there is a normal superimposed ovarian cancer which is seen in this patient. Second thing clinically that we see in this patient is the typical clinical history. These patients will typically present like a ADAM. In ADAM, we used to see a viral flu kind of a picture, followed by which we have psychiatric symptoms and temporal lobe symptoms which will be seen. So whenever you see a viral flu which is followed by psychiatric symptoms or temporal lobe, your clinical diagnosis is going to be autoimmune encephalitis, and you are going to suspect in imaging also the similar kind of a spectrum. But unfortunately, the most common type of type 2 is NMDAR, in which nearly in literature what they say, 60 to 90% will have a normal MRI. So if in the clinical profile, if they suspect autoimmune encephalitis and your MRI is going to be normal, make sure that you recommend FDG PET, because if the EEG is especially typical, then you are supposed to rule it out by doing a FDG PET, in which you will be able to see these findings. These pickups are better seen. Coming to the next thing, this is VGKC, voltage gated potassium channel encephalitis. These potassium channels are more in the temporal lobes and the limbic system. So because of which, again, the temporal lobe and the limbic system are more commonly involved. Extra limbic symptoms are very rare, actually. 1 in 5% of the cases it will be seen. These patients clinically present with medically intractable epilepsy. There would be continuous seizures which will be throwing, which won't be subsiding with anti-epileptic medications. The differential diagnosis in imaging is going to be confusing with an Alzheimer's disease if it is an elderly patient, and mesial temporal sclerosis if it is a younger patient, because both of them are going to have predominantly a hippocampal or the limbic system involvement. VGCC stands for voltage gated calcium channel encephalitis. Again, temporal lobe and limbic system is involved, but more important is there is a migratory kind of an extra limbic involvement. What do we mean by extra limbic? Here it is the frontal, parietal, and cortical lobes. Here we are able to see that the parietal lobe is involved, parietal and occipital lobe is involved. Later at another point of time, it is a left frontal lobe which is involved, and the left occipital lobe is involved. So there is a migratory pattern. In an earlier imaging, it is one part of the lobe. In a subsequent imaging, it's a different part of the lobe which gets involved. So that is migratory extralimbic manifestation, which is more common in VGCC when compared to VGKC. Clinical profile is of women and young children. These patients can present with cortical enhancement, cortical laminar necrosis. So imaging wise, what we are going to get ourselves confused with, is it a case of a recurrent strokes? Whether this patient had a stroke earlier in the side, another stroke here. In the imaging, you'll think that maybe this patient has multifocal stroke involvement with the cortical enhancement in the subacute phase and cortical laminar necrosis, which is seen in the subacute to chronic stage of the infarct. And so what is going to help us in ruling that out is the migratory pattern. So whenever you see this migratory kind of a pattern, start thinking about autoimmune encephalitis. But again, another clinical vignette is that these migratory kind of involvement can also be seen in Graves' disease and Hashimoto's disease. How do you differentiate between these two? Hashimoto's can have a more of a leukoencephalopathic component when compared to Graves' disease. This is another patient in which only the cerebellum is involved. You can see just the cerebellum, white matter is involved actually. This is also VGCC encephalitis. Coming to the last, which is the GABA encephalitis. Gamma butyric acid receptor. I'm not very adept at remembering these names. So this is a GABA receptor, which has two types, A and B actually. So this is again is going to have a limbic and temporal lobe involvement. The type B is very important because it can precede cancer. See, this GABA, NMDAR, VGKC, VGCC all comes under group 2. But this is one subtype of group 2 which can be followed by cancer. Like after 2 to 3 years of diagnosis of a GABA encephalitis, these patients can develop cancer. So still that association of small cell cancer neuroendocrine tumor is known to occur with the GABA type B kind of encephalitis. So this has a relatively good prognosis when compared to the other types actually. The GABA A type receptor has no cancer, but it has more of an extra limbic features which is seen. So that summarizes our autoimmune encephalitis. We saw the clinical definition in which this patient's present with seizures, memory loss, and there should be absence of that is metabolic etiology, infective etiology, and METs, in which we are able to see the characteristic EEG findings and MRI findings. And two types, group 1 and group 2 we saw. Group 1 was anti-Hu, anti-Ma, anti-Ta, and anti-CV2, anti-GAD. Group 2 was going to be an NMDAR, VGKC, VGCC, and the GABA R type. And if you are clear with this concepts of autoimmune encephalitis, we'll move on to a more comprehensive discussion of autoimmune encephalitis in our next video. Thank you.